Biomed Sports Medicine is pleased to introduce the ACL Performance Enhancement Program, a progressive training rehabilitation program focused on getting athletes back to sports safely and effectively.
There's a high incidence of ACL injuries, particularly in women. Some people seem to be genetically predisposed, and how confusing it was to decide on graft choices and return back to sports. ACL surgery is evolving as far as we are deciding graft choices, tunnel placement, single or double bundle grafts, and fixation systems. ACL rehab is also evolving from immobilization, accelerated rehabilitation, sport-specific rehabilitation, and performance ACL enhancement programs, which we'll talk about today. The most common question the doctor and the athlete has is when they can get back to competitive play. The literature is quite vague on this. There's reports as early as 4 months to approximately a year and a half. The answer is much more complicated than you would think because it involves many things with the ACL injury. There are factors the surgeon can control. One is the mental aspect, and that is the patient's acceptance of the injury and the emotional fortitude to proceed with the commitment of recovery. Another factor the surgeon can control is the knee status, and that is to obtain adequate motion of the knee prior to surgical intervention, to have decreased swelling, and return of the quad and hamstring control. Finally, the most important thing the surgeon can control is to do a technically competent procedure. That is to avoid intraoperative or postoperative complications, get excellent tunnel placement with excellent fixation. The other thing that drives when an athlete can return to play is the severity of the ACL injury. Severity of the ACL injury matters. A low, isolated ACL injury without a meniscus tear, without a condylar injury, with no collateral ligament injury, and a small bone bruise will ultimately have a better result and recover much quicker than a high-energy injury with an ACL tear, large bone bruise, chondral defect, a meniscus that requires repair or resection with an associated collateral ligament injury. These things take much longer to recover, and this will change the timeline compared to an isolated injury alone. Other factors that determine return to competitive play are things such as the position that the player plays. Obviously, if you play offensive line, you can get back sooner than if you're a defensive back. The sport is important. Basketball will take much more time and is much more difficult to get back competitively than a sport such as alpine skiing. Genetics plays a part. There are some people that recover much quicker and do much better with rehabilitation and healing than other people. And finally, luck and motivation are a factor in recovery from ACL surgery. I've also found in my experience graft choice makes a big difference in recovery time. Fastest is allograft, contralateral hamstring autograft. Equal morbidity and recovery is ipsilateral hamstring graft and contralateral bone tendon bone graft. And the slowest is ipsilateral bone tendon bone autograft.
It became pretty apparent early on that there were no prevention programs for postoperative ACLs. Most of these programs were geared for prophylactic injury prevention.
We decided to go ahead and start a program to accelerate the recovery after ACL surgery. Programs are out there to help prevent ACL injuries. There's been research for 10 to 15 years, preventive programs, particularly in female athletes. We incorporate a lot of these principles in the recovery and rehab after a reconstructed knee. And we've made this a part of our program after ACL surgery to take the principles that were used to prevent ACL injury and incorporate it into our recovery.
Most of our patients that have been through the program express nothing but satisfaction as far as their abilities to return to their sport. In fact, many of them have demonstrated increase in their vertical jump height, increase in their power, and strength that exceeds their pre-injury status in their knees.
The feedback I've gotten from patients that come back after completing this program versus the more traditional rehab, the patients that do this program have much more ownership in the rehab than the people going through the what I call rehab burnout of going to physical therapy, working on motion as well as strengthening, and getting very bored. This program gets them much more involved It allows them to set goals, and they actually see increase in gains of things better than their pre-injured knee. My recommendation is to consider this ACL enhancement program as part of your ACL practice. My experience in dealing with hundreds of patients, they come back quicker, stronger, and with more confidence, and it's a great way to give them ownership in the rehab process. This program has helped me because there are a lot of good surgeons in my community, and the difference on how I do a knee versus how they do a knee sometimes is very small. But I think a lot of my patients do better, not because of my technical abilities, it's because of what I do after the surgery, is to get involved in a program like this. They do well by getting good strength, function, and confidence, and that makes me look good.
The ACL Performance Enhancement Program consists of progressive plyometrics, beginning around 8 weeks postoperatively, extending 4 to 6 months, and leading up to medical release back to sports activities. Traditional rehabilitation protocols have often utilized a time-based approach to treatment progression. This cookbook approach has often caused clinicians to push their patients more aggressively than appropriate. Also, one of the most controversial and challenging dilemmas to the clinician is deciding when to safely progress a patient from standard rehabilitation into impact and more sport-specific training. The purpose of the following protocol is to take a research-derived, criterion-based approach to progressing a patient all the way back to their given sport. Specific clinical milestones have been outlined and must be met before progressing into the next phase of training. Following such guidelines allows for safe monitoring and control of the many variables that go into progressing rehabilitation as safely and quickly as possible. It has been estimated that up to 90% of all ACL injuries occur from non-contact mechanisms. Clinical studies have indicated that such injuries usually occur during a landing from a jump or from deceleration prior to a change in direction. Usually, this involves an awkward movement or a need to unexpectedly change direction prior to the injury. The same studies have shown there usually is an apparent valgus or dynamic valgus in the coronal plane prior to injury. This vulnerable position, or the point of no return for ACL injury, has been defined as internal femoral rotation, knee valgus, external tibial rotation with foot pronation. Knee flexion angles of 45 degrees or less have shown an increase in anterior tibial shear as the quadriceps is contracting eccentrically to slow the landing momentum. Athletes that demonstrate these mechanics are termed ligament dominant and very susceptible to injury. During all phases of the protocol, we are constantly instructing patients to minimize these faulty movement patterns, stressing that athletes land with strong athletic positioning utilizing the quads, hamstrings, and gluteals to absorb and control the amount of shear at the knee through co-contraction. This form of training is referred to as plyometric exercise. Plyometric exercise can be defined as an activity in which an eccentric muscle contraction or lengthening is quickly followed by a concentric muscle contraction or shortening and is repeated for a given duration. This process of contract-lengthen, contract-shorten is often referred to as the stretch-shortening cycle. Almost all athletic movements involve this stretch-shortening cycle. Plyometrics can be broken up into 4 stages: the pre-activation stage, the concentric stage, the eccentric stage, and the amortization stage. Most injury rehabilitation programs fail to realize that an eccentric muscle contraction can be up to 3 times more forceful than a concentric muscle contraction. This is why plyometric exercises are important in the final stage of rehabilitation, to condition the muscles to handle the added strain of eccentric contractions. Integrating patients back to impact activities requires dosing the intensity, duration, and amount of activity. The suggested frequency of training throughout the impact protocol is 3 days a week on non-consecutive days. In early stages, clinicians have their patients warm up adequately and start the program with entry-level plyometric activities. This prevents poor form secondary to muscular fatigue. Throughout the later stages of this program, patients are challenged to maintain good form even while fatigued. As most injuries occur after fatigue, this trains the athlete to maintain good sound joint mechanics when fatigued. We continue appropriate traditional progressive resistive exercise in conjunction with the impact protocol, targeting muscle groups that display deficiencies. Examples of traditional strength exercises extend far beyond the scope of this DVD. There are a total of 5 stages of rehabilitation to complete before a safe return to competition can be considered. Estimated timeframes are outlined throughout this program, yet not all patients progress equally, as there may be complicating factors that may hinder or expedite rehabilitation. Impact Phase A. Entry-level plyometrics, beginning at 8 to 10 weeks. Impact Phase B. Transitional plyometrics, Level 1 agility, beginning at 10 to 12 weeks. Impact Phase C. Level 2 agility, sport-specific movement, at the 12 to 14 week mark. Impact Phase D. Level 3 agility, high-level sport-specific movement, at 14 to 16 weeks. The athlete then progresses to Impact Stage E, the jump program, which begins around 16 to 22 weeks. During this phase, the functional strength training would be administered on a Monday, Wednesday, Friday routine, while the plyometric training would occur on Tuesdays, Thursdays, and Saturdays. Once an athlete completes this protocol, they're put through a comprehensive return-to-sport test. If the clinician, athlete, and surgeon all agree that the clinical goals are met, then medical release can be considered. Some important components that everyone should consider include: choose patients appropriately, as not all patients need to reach this level of rehabilitation. Follow functional testing criteria to assure safe participation and progression into each stage. Know the physician, as some surgeons want to prolong soft tissue healing time. When in doubt, contact the physician prior to progressing to more vigorous activity. Utilize rest breaks to restore short-burst creatine phosphate and fast glycolytic energy systems. Double or triple the time duration of the desired exercise for its subsequent rest and recovery period. Encourage patients to be hydrated and properly nourished prior to exercise. Consider proper footwear and use a firm but forgiving surface. Note that correct posture and body alignment is the focus for all stages. Utilize controlled, quiet landings, landing toe to heel for vertical touches, heel to toe for horizontal touches. Minimize amortization stage. The landing on the first jump should be the beginning of the next jump, stressing good, quick, eccentric muscle control. Land with knees bent greater than 60 degrees of flexion. After 60 degrees of flexion, the hamstrings and quadriceps work together through co-contraction. Land with strong, athletic positioning, with the feet shoulder width apart, knees comfortably flexed, shoulders back, chest over the knees, and the center of balance over the balls of the feet. Avoid dynamic valgus moment or knock knees positioning with landing.
The first functional test we do is just a simple squat test. Really simple. What we're going to have her do is do 10 squats. She's going to go as low as she can comfortably. What we're looking for is symmetry between the limbs. If she's favoring one leg, keeping good alignment. We're listening for crepitus in and around the patellofemoral joint, looking for any signs of abnormal joint stress, obviously monitoring pain, any clicking or any abnormal signs of joint stress. So Katie's going to do 10 squats. Normally I'd be in front watching her from the front. Sometimes I'll put my hands on their knees to feel for any patellofemoral issues like chondromalacia. It's kind of a subjective test too. I need to ask the patient how that feels. If they're having a lot of pain with this, they're not going to be ready to enter the impact protocol. Simple but effective. If someone can't do this comfortably, then they're not ready to start the impact protocol. And that is the squat test. The next test we're going to do is the 1 minute eccentric step down test. What this is a good measure of is readiness to accept weight on the limb, as well as measuring what's called a force endurance ratio. Simple test. We do this pretty early on in rehab, frequently monitoring patients' strength and progression with the protocol. What she's going to do, we're going to get a timer. We're going to time her for 1 minute. She's going to do as many dips as we can here, and I'll have her demonstrate here. We're not going to do the full minute for time's sake, but go ahead and start, Katie. We're going to count reps. She's going to go as fast and quick as she can, all the way straight with each rep. You're going to watch their form. People have a tendency to really hip hike on that, and if they're doing that, they're not doing this correctly. So we're counting reps for the entire duration of the minute. Okay, good. So say the minute's up. We're going to switch to the other leg. We start the timer, 1 minute. Here we go. Counting reps once again. After that minute is up, we divide the surgical leg by the non-surgical leg, and that gives us what's called the force endurance ratio, and that is what we use as one of our criteria to progress further into the protocol. We're looking for a certain amount of percentage, usually anywhere from 60 to 80% at the surgical leg compared to the non-surgical, and that is the timed 1 minute eccentric step-down test. One of the functional tests we do in the program is a broad jump test. We do this towards the end stages of this program. It measures power, measures force production out of the hips and the quads. It's a good gauge for if our athletes are favoring one leg or not favoring one leg. So the way we do this is we usually have our patients do a graded warm-up. We make our patients interlock their fingers behind their back. This eliminates them using momentum. We want to measure power out of the legs. I'm going to have her do a graded warm-up. I usually tell the patient to do 2 jumps at 50% effort. So Katie, go ahead. So I'm watching her mechanics as she does this. She's going to return. We're going to do another jump at 50%. Good. One more. And we're going to ramp this up to a 75% effort now. Good. One more at 75. Okay, and now we're going to do 3 jumps at 100% effort, and I'm going to measure these jumps, and we're going to average these jumps. It's a good way for us to measure progress. So when you're ready, 100% effort. Good. Get a measurement. Go ahead and head on back. Again. So the hands are behind the back the whole time. Okay. Head on back. And one more. Okay, head on back here. So I'm going to take all those jumps and average them, and that's going to be our average for the functional broad jump test that we monitor throughout the later stages of the protocol. The next functional test we're going to do is the single leg hop test. This is kind of the gold standard as far as us measuring progression throughout the protocol. This is one of the biggest tests we look at if an athlete's ready to return to their given sport. It's kind of like the broad jump test. What we're going to have them do is we're going to do a graded warm-up. We keep their hands behind their back. I usually have them test their non-surgical side first. So what we're going to do is the graded warm-up. She's going to start with her right leg, 50% effort. Good, head on back. It's a good way we can measure patients' confidence in their leg too. Good, okay, head on back. We're going to do this at 75% effort. Okay, one more at 75. Okay, and now we're going to measure 3 jumps at 100% on our right leg, and we're going to repeat the process on the left leg. Okay, good. Good. And one more. Okay, good. All right, she's going to warm up her surgical side now. Same manner. 50%. Okay, good. Okay, good. 2 at 75. Okay, and now we're ready. 3 at 100%. And I always tell my patients, don't go nuts. We're not trying to set records. We want you jumping comfortably. So I'm going to get a measurement here. Okay, 2 more here at 100%. Good. And 1 more here. Good. So the way we calculate the hop index is I add all 3 jumps on the right leg, and then I add all jumps on the left leg, and we divide that total by each other, and it gives us a percentage. Our discharge criteria is an 85% hop index, meaning that the surgical limb has 85% the capability on the hop test as the non-surgical side. And that's the single leg hop test. One of the last functional tests we do is a vertical jump assessment. In order for us to get this set up correctly, I'm going to set this to our standing reach height. So step in, we're going to get the veins even with the tip of our fingers. And the top vein is 24 inches, so if you've got someone who can jump over 24 inches, you're going to have to adjust it accordingly. So what I'll have her do, we're going to do a few warm-up jumps, so 3 warm-up jumps, so get nice and low, and you're going to jump up and hit the tallest vein possible, okay? So 2 more there. Okay, so what I usually do is we get the veins that we know she's going to jump higher than out of the way, and then we're going to measure 3 jumps like we did in the broad jump test and the hop test, and average those jumps for a mean vertical jump assessment here. So now when she's ready, we're going to do 3 jumps and record those jumps at max effort here. That was 17.5 inches. That was 19 inches. Good. And that was 19.5. So we go by the tallest vein that she hit. So that is how we measure our vertical jump assessment. We do this in the later stages of the impact protocol.
To proceed to impact phase A, the patient should meet the following criteria. The patient should have full extension with knee flexion up to 125 degrees. There must be minimal to no joint effusion or no joint line tenderness, 65% quad strength or greater, 50% of a quad to hamstring ratio, a satisfactory Lockman or drawer test, a score of greater than 6 on the Cincinnati Knee Rating System, and a 1-minute step test greater than 60%, a satisfactory squat test, and step down test.
One of the first plyometric exercises we use is using the shuttle machine. We use this machine for a variety of different exercises throughout the phases. The nice thing about the shuttle is we can control the amount of resistance going through the leg. It's got elastic cords with varying resistance. We usually start out pretty light and then work our way up towards more towards body weight. The other nice thing is, go ahead and lay down, is I can control her knee angle. So that 60-degree angle that's so key, we can control. She's at about 90 degrees here, so I'm going to adjust this, have her scoot back a little bit to where we can teach her to land in that magic, 60-degree angle where you get the most co-contraction between the quadriceps and the hamstrings. So the first exercise we'll do is just a bilateral jump. Throughout the phases, the semantics of the words I'm going to use, jump means a 2-leg and a hop means a 1-legged jump. So when I say jump, it's going to be a bilateral jump. Unilateral jump will actually be called a hop. So go ahead and push through your feet. And she's going to land nice and soft, toe-to-heel landing, decreasing the time that her feet are on the platform. And we usually have our patients start with a set of 20. And the whole time I'm watching her joint alignment, a lot of times what we'll see with patients is they're going to favor their surgical leg. And her alignment looks good, so we're looking for her knee to stay over the toes. After she has completed this exercise, we usually have her rest anywhere from 30 seconds to a minute in between sets, and we usually do around 3 sets of 20 in this early level phase. The next progression on the shuttle machine we do is alternating between the left and right feet. The setup's going to be the same, so we're looking for the 60-degree angle at the knees. What she's going to do, she's going to push off her left leg and land on the right leg. Same joint mechanics, landing toe to heel, keeping her alignment good and sound. So go ahead. So the whole time we're watching her alignment, making sure she's not getting that dynamic valgus or knock-knee position. Other thing we can assess is limb dominance. This is a good exercise to train people to get comfortable loading and unloading their surgical leg. And we utilize the same rest breaks on this exercise. So 30 seconds to a minute based off of how many repetitions she does. This is all kind of at the discretion of the clinician. One of the most important exercises throughout the protocol, and it is repeated throughout the protocol with different variations, is what we call lateral bounding in place. What we're going to have Katie do is get into that good athletic position, butt back, a little wider on the feet. And what we're going to have her do is almost like a weight shift. She's going to land in this flex knee position, shifting her weight from right to left. This is the first body weight exercise we do in the coronal plane. It's similar to cutting, and as we progress throughout the program, we're going to get more aggressive and add a few tweaks to this exercise. So what she's going to do, she's going to shift her weight to the right, load and unload, load and unload. So at first, we want her just getting confidence in that leg and that surgical knee. And as she progresses, we're going to have her go quicker, decreasing the amortization phase or when her foot's on the ground. And obviously work more for more explosion and power. Early on though, we just want to go nice and slow with this, making sure they keep good sound joint mechanics like she's doing. And the 20 to 30 second bout is usually what we start with. So this is lateral bounding in place. We start this entry-level exercise in the first phase. The next exercise we do early on in the impact protocol is we start to utilize the slide board. We do this for a couple of reasons. This one's very similar to lateral bounding in place, which we already went over. What we're encouraging her to do is to drive and push off both her surgical and non-surgical leg. How this is different than lateral bounding in place is challenges the balance and the proprioception just a little bit more. So what I'll have her do is get in that good athletic position, in that squat position, push and drive off her right leg, sliding over to the left, and repeating that back and forth. There's also a little more aerobic involvement with this exercise. Once again, we do this for time, usually starting anywhere from 20 to 30 seconds. And usually we have them do about 2 to 3 sets. So she's driving, getting low on that knee, pushing. This is good. It's real hard to favor your surgical leg and do this correctly. Another reason I like this exercise. So the whole time we're going to monitor both her mechanics and any signs of joint distress. At any point she experiences pain or has any symptoms at all, then we're going to discontinue the exercise and either modify it or not do it for the day. Good. And that is the slide board exercise. In the first phase, we begin jogging in place. This is the first full body weight exercise we do. You just do this to get confidence in the knee, to assess their alignment, make sure they're loading the joint correctly, evenly. Usually have them do this for 20 to 30 seconds. Then we will progress this to high knees. So she's going to bring her legs up nice and high. We stress letting her hips control where her knees are in space. A little more impact into the joint. 20 to 30 seconds. Once again, just watching for any abnormal signs of joint stress. Then we move this into gluteal kicks. This gets the hamstrings involved. As we've talked, the hamstrings are very, very key at stabilizing the knee and protecting that new ACL. Once she's run through that for 30 seconds, we go right back to jogging in place. Back to high knees. And then lastly into the gluteal kicks. We usually run through those twice, each one 30 seconds at a time.
To proceed to Impact Phase B, the patient should meet the following criteria. The patient should have full extension with knee flexion up to 130 degrees. There must be minimal to no joint effusion or no joint line tenderness, 70% quad strength or greater, 60% of a quad to hamstring ratio, a satisfactory Lachman or drawer test, a score of greater than 6 on the Cincinnati Knee Rating System.
So progression on the shuttle, the next jump we're going to do is a bilateral grid jump. What she's going to do in this position, we got the shuttle divided into quadrants. We're going to jump from one quadrant to the next. This is a good exercise at working multiple planes, maintaining good joint alignment, kind of stressing the knee in different angles, more of a sport-specific type of activity. So what she's going to do, we have got the same setup, 60-degree angle. She's going to jump, and then we're going to start in a clockwise position. So she's going to jump and then land in the grid to the right, then jump and land in the grid down below that one, and then we're going to go in a clockwise pattern. So go ahead, Katie. So same mechanics, we're looking for soft landings, watching those knee angles. As we go through the phases, we begin to add more and more resistance on the shuttle, working our way up to body weight, which will begin in the next phase. Okay, so after 20 jumps, we'll have a reverse in a counterclockwise manner, working the joint a little differently. So after 30 seconds to a minute rest break, we'll have her go counterclockwise here, same manner. And that is the bilateral grid jump.
Here in Impact Phase B, the athlete repeats the alternating shuttle exercise completed in Phase A, entry-level plyometrics.
Same joint mechanics, landing toe to heel, keeping her alignment good and sound. The progression on the bilateral grid jump is moving that into a unilateral position. We usually do this on the surgical leg only. This builds confidence in the surgical leg, making sure that they're getting the power, the push-off that they need, and it also allows the patient to become comfortable landing and loading that surgically repaired knee. So she's going to do the same thing as we did before with the bilateral grid jumps in a unilateral leg position. So she's going to start clockwise. It's real imperative on this one to really watch that valgus angle at the knee, and if you find them doing that, then you need to correct it and make sure they're jumping with safe, sound mechanics. We don't want to hurt them. We usually start with 20 reps as well on this one. And that is the unilateral grid jump. The next progression in the lateral bounding exercises is 3-point lateral bounding in place. The mechanics are the same, but we're going to move it into 3 different planes of motion, challenging the balance and core strength of the patient. So she's going to get into her start position and move through the cones, keeping good sound mechanics all the way through, landing in that flexed knee position. After the desired time, we're going to switch the legs, and she's going to be pushing off her other leg. Switching the legs becomes more important as we add resistance, which is the next progression in this exercise. So this is 3-point lateral bounding in place. The next progression of the lateral bounding in place would be lateral bounding into rotation. The mechanics are fairly similar, but what we're going to do, she's going to move from the coronal plane to the sagittal plane all in one motion. We're going to load both legs equally. What she's going to do, she's going to shift her weight to the right and rotate her right leg forward, return into the start position. We're going to do this for 20 to 30 seconds. As she becomes more and more comfortable, more confident, we're going to have her go higher and farther with each bound here. Soft landings are key. Okay, good. And we're going to have her switch her legs now. So she's going to push off her right leg, and the left leg is the one that's going to be rotating into the sagittal plane here. Just watching knee alignment and that flexion angle. We always tell patients we'd rather them land too deep than too shallow. After 60 degrees of bend, it's nearly impossible to tear your ACL. Good. And that is lateral bounding with rotation. Some of the early agility exercises we start early in the phases, we use a step for. Usually we start our patients on a 4-inch step and progress that all the way up to a 12-inch step. This again is at the discretion of the clinician. The first exercise I'm going to have her do is what we call quick feet. She's going to step up on the step. It's almost a jogging motion, and she's going to repeat that as quickly, as safely as possible. So there's very minimal impact in the joint. We're stressing form first, then quickness. We usually start with about 20 seconds of this, and we usually progress in 10-second intervals along with the height of the step. So if she just went for 30 seconds, a good rule of thumb, we usually double or triple the time of the exercise for her rest break. So she's going to rest a minute to a minute and a half in between exercises. The next exercise we usually do is what we call the ollie shuffle. These first two exercises are all in the sagittal plane, so they're relatively safe. There's not a lot of stress at the joint. That's why we start with these. So the ollie shuffle, she's going to put one foot up on top, and she's just going to switch her feet back and forth. And once again, we're stressing form first, good alignment, then quickness. As she progresses, she'll start going quicker, getting as many touches as possible in the time frame. After that, we'll move into the coronal plane. We'll have her start to the side. We're going to do what we call lateral quick feet now. So she's going to put both feet up on the step, move to the right, and then both feet off the step. We want people to go nice and slow. Make sure your patients get the form before they try to pick up the speed. Soft landings are key. It shouldn't sound like a herd of elephants. And as she gets more comfortable, I'm going to pick the speed up. Instead of repetitions, we almost always use time for exercise dosing here. The last exercise we do with the step is what we call lateral skaters. She's going to put the top foot on the step, and she's going to do a little hop and actually switch her feet. So one foot's on the turf, one's on the step at all times. That flexion angle on the top step is real important. If you see, she's getting below that 60-degree mark, which is super important for hamstring and quad co-contraction. And as we discussed before, your rest breaks are real imperative in this. If you do not let your patients rest, a lot of them will bonk, get sick, all of the above. And that is our entry-level step agility exercises. Starting in the second week of Phase B, a return to jogging program is initiated on the treadmill. The patient begins by walking at a brisk pace for 3 minutes. At the 3-minute mark, the treadmill is sped up to a jogging pace for 1 minute. This is usually somewhere right above 4 miles per hour. After this minute, this is followed with a 1-minute walk. After she has walked for a minute, we speed the treadmill back up and continue with a 3-minute jog. Once again, we follow the jogging portion with a 3-minute walk. And the whole time we're watching the patient's readiness to put weight on their leg, watching for any gait deviations, pain, joint distress, or any other abnormalities throughout the whole activity. Should the patient continue to exhibit good tolerance to this, they will end with a 5-minute jog and 1-minute cool-down walk. Once it is evident that a patient is tolerating this well, a jogging program can be initiated at 3 times per week.
To proceed to Impact Phase C, the patient should meet the following criteria. The patient should have full extension with knee flexion up to 135 degrees. There must be minimal to no joint effusion or no joint line tenderness. 75% quad strength or greater. 60 to 65% of a quad to hamstring ratio. A satisfactory Lockman or drawer test. A score of greater than 7 on the Cincinnati knee rating system. And no pain or gait deviation during a 10-minute jog.
Starting around phase C, we begin to integrate full body weight plyometrics. We usually start with the jump rope. It's an easy way to transition people into the full body weight joint stresses. This is a good exercise, good conditioning exercise. It's great to assess their alignment, your joint alignment, watching for those abnormal joint alignments we talked about earlier. And you want to really watch their form. We usually have our athletes go for a minute at a time. We also have our athletes jump rope with alternating feet. This really loads the front leg a little more. We usually have our athletes go for a minute at a time. Once again, watching her alignment, watching her impact, trying to get them laying nice, soft.
In each of the impact phases, we repeat some of the entry-level agility exercises. Repeat the quick feet step work.
A good rule of thumb, we usually double or triple the time of the exercise for her rest break. So she's going to rest a minute to a minute and a half in between exercises.
Repeat the Ali Shuffle agility exercise.
Getting as many touches as possible in the time frame.
Repeat the lateral quick feet agility exercise.
Instead of repetitions, we almost always use time for exercise dosing here.
And finally, repeat the lateral skaters agility exercise.
That flexion angle on the top step is real important. If you see, she's getting below that 60-degree mark, which is super important for hamstring and quad co-contraction. This exercise is lateral bounding with rotation. The mechanics are very much similar to the lateral bounding with rotation in place, with the 3 points added to it to challenge the balance and proprioception of the athlete. As they become more and more comfortable, we're going to encourage them to decrease the amortization phase and work on exploding each jump, going for more distance and more power off each jump. And that is 3-point lateral bounding with rotation. After we've started the patient on a jogging program on the treadmill that they're tolerating well, we transition them into the sport cord. With the sport cord, we're going to use this for the next 4 weeks. We're going to start by having the patient jog forward. Usually we start at about a half speed here, and in return. And we're going to do this for the duration of phase C. When we get into the advanced phase in phase D, we're going to move it up to a 3/4 pace. So go ahead and ramp it on up. So it's near full sprint here. The added resistance just makes the muscles work overtime. This is really forcing the glutes and hamstrings to drive. Okay? And after that, we're going to spin her around and we're going to do the same thing backwards. So once again, in phase C, we're going to do this at about a half speed here. And we group all these sport cord exercises together. Patients are usually on this for a while. And as we get into phase D, we're going to have her go at 3/4 pace here. So really driving through those legs. Good. And that's sport cord forward and backwards. In phase C, we begin to do the lateral bounding exercise with the sport cord. So we're going to do 3-point lateral bounding with the sport cord for resistance. This really focuses on power. So he's going to drive to that first cone, soft landing, same landings we've been talking about all the way through the program. Driving off that left leg. That left leg is getting overworked. This really challenges the balance and core stability throughout the exercise. Okay, and after she's done the desired sets and reps, we're going to repeat this driving off the other leg.
In the second week of phase C, a dynamic warm-up is added. and allows for increased elasticity of muscles and tendons during sport-specific movements prior to focused training.
We're going to do this for about 30 seconds. After 30 seconds, we're going to have them do arm circles forward, walking down. We need about a 12 to 15 yard area to do this warm-up. And back. And normally we would have her do 2 laps here. We're going to do arm twist, trunk twist. So she's walking at a brisk pace. We want to keep moving throughout the exercise and warm up here. This is also a good way to kind of assess her readiness to move. She's going to do hip circumduction, keeping moving. She's going to open and rotate the hips and stretch the groin. So as I said before, normally we're going to do 2 laps of each here. We're going to have them go into a skipping bound motion. So I want to get in that front leg nice and high. Like I said, this is a good way to assess someone's ability to both push off the affected leg and see if they're favoring one leg or another. Okay, now we're going to move into high knees. So she's going to try to get as many touches as possible. And we're going to move into gluteal kicks. Keep moving the whole way through this. A lot of these movements are actually what we use on our return to sport test too. So it's a good thing that we have athletes practice this for when we get to that point. Okay, now we're going to move into side shuttle. She's going to face one direction, stay in that flex knee position. And she's going to do 2 laps like that. Now we're going to move into cariokas. Important with this, what I want her doing is turning from the hips, not from the knees. We don't want to be twisting the knee. She's going to come back facing the same direction. Okay, now we're going to have her sprint forward, and she's going to backpedal. Okay, lastly, we're going to have her stand in place, and she's going to bounce up and down off her toes, and that's the dynamic warm-up. We're going to do this for the remainder of the protocol. Starting in phase C, we move away from the step agility exercises and move into the agility ladder. This is more sport specific and puts a lot more demand on the knees. So we're going to run Katie through a series of exercises. The first one we're going to do is what we call quick feet forward. So she's going to go as high as high knees. So she's double touching in each rung here. Okay, and we usually do this 3 times. The next one we'll do is lateral high knees, which she's going to move in the coronal plane with her legs pumping nice and high. Her hips are controlling where her knees are in space. We go back facing the same direction, working the legs a little differently. Then we go into lateral quick feet, which are ins and outs, and we're going to do this 2 different ways. We're going to do the first one with her leading with her front foot. This challenges dexterity, so she's going to go in and out, and then go for speed. And she's going to go back facing the same direction here. So this is lateral quick feet, in and out with front lead. Now we're going to reverse this, and she's going to do back foot leading. But you can see there's more rotation in the hips with this. It's a little more challenging movement. This is lateral quick feet in and out with the back lead. From there, we'll move into the ollie shuffle. She's going to, it's very similar to what we were doing on the step. She's going to jump up and switch her feet, moving in and out each rung. So a lot of rotation at the hips, and she's going to reverse that. When we first start these, usually we do 3 times down and back of each exercise. The last one we're going to run through we call the icky shuffle, and this is our first real hard cutting exercise. So she's going to start cutting on that outside leg, and she's going to go back doing the same thing here. So these are the ladder agility drills that we do up until the jump program begins.
To proceed to impact phase D, the patient should meet the following criteria. Range of motion must be within 90% of the contralateral limb. There must be minimal to no joint effusion or no joint line tenderness. 75 to 80% quad strength or greater. 50 to 70% of a quad to hamstring ratio. A satisfactory Lockman or drawer test. A score of greater than 7 on the Cincinnati knee rating system. And a single leg hop index of 50% and broad jump with sound mechanics. In Impact Phase D, we move into high-level sport-specific movement by repeating the Phase C routines. starting with the dynamic sports warm-up, then on to the sport cord and agility ladder drills, adding both intensity and repetitions.
We begin to integrate a dynamic warm-up. It's kind of a calisthenic-based warm-up, and it kind of covers the body from head to toe. It usually takes about 5 minutes for the athlete to run through. Jogging in place, we're going to do this for about 30 seconds. After 30 seconds, we're going to have them do arm circles forward, walking down. We need about a 12 to 15 yard area to do this warm-up. And back. And normally we would have her do 2 laps here. We're going to do arm twist, trunk twist. So she's walking at a brisk pace. We want to keep moving throughout the exercise and warm up here. This is also a good way to kind of assess her readiness to move. She's going to do hip circumduction, keeping moving. She's going to open and rotate the hips and stretch the groin. So as I said before, normally we're going to do 2 laps of each here. We're going to have them go into a skipping bound motion. So I want her getting that front leg nice and high. Like I said, this is a good way to assess someone's ability to both push off the affected leg and see if they're favoring one leg or another. Okay, now we're going to move into high knees. So she's going to try to get as many touches as possible. And we're going to move into gluteal kicks. Keep moving the whole way through this. A lot of these movements are actually what we use on our return to sport test too. So it's a good thing that we have athletes practice this when we get to that point. Okay, now we're going to move into side shuttles. She's going to face one direction, stay in that flex knee position. And she's going to do 2 laps like that. Now we're going to move into cariokas. Important with this, what I want her doing is turning from the hips, not from the knees. We don't want to be twisting the knee. She's going to come back facing the same direction. Okay, now we're going to have her sprint forward, and she's going to backpedal. Okay, lastly, we're going to have her stand in place, and she's going to bounce up and down off her toes, and that's the dynamic warm-up. We're going to do this for the remainder of the protocol. We transition them into the sport cord. With the sport cord, we're going to use this for the next 4 weeks. In phase D, we're going to move it up to a 3/4 pace. So go ahead and ramp it on up. So it's near full sprint here. The added resistance just makes the muscles work overtime. This is really forcing the glutes and hamstrings to drive. Okay, and after that we're going to spin her around and we're going to do the same thing backwards. And as we get into phase D, we're going to have her go at 3/4 pace here. So really driving through those legs. Good, and that's sport cord forward and backwards. Starting in phase E, we also begin side shuttles in a lateral motion in the coronal plane. This really works on drive and getting the athlete ready to begin agility and cutting drills. So we'll have her get in that flex knee position, that sport ready position, and then drive to the right through the legs, picking the feet up, and then back. Usually start with 20 repetitions, and we'll repeat this facing the other direction, so both legs are worked equally. And you really will notice a difference a lot of times in the push off and power out of the surgical leg. The last of the lateral bounding exercises starts in phase D. This is lateral bounding with rotation with the sport cord for added resistance. So it's going to be the same form we've been doing. She's going to turn and land in that flex knee position, moving from the coronal to sagittal plane each time. Good. That's 3-point lateral bounding with rotation with the sport cord. Starting in the second week of phase D, we continue to progress the sport cord exercise into what we call the 3-point drill. We're going to do this both forward and backwards. So what I'm going to have Katie do is she's going to run forward to the first cone, and then she's going to shuttle over to the right, touch the cone, back to the middle, all the way over to the left cone, back to the middle, and then she's going to go backwards. So this is a multi-planar exercise, and as she gets comfortable, we're going to ramp up the intensity. So we're going to do 20 reps in a row here. So when you're ready. And she's going to continue and repeat that. Good. And then I'm going to have her turn around and we're going to repeat this going backwards as well. This works a little more on the quadriceps by going backwards. So I have our patients get really low and drive through their legs. So I always have people start slow and then ramp up the speed and intensity. So go ahead and ramp it up a little bit here. Good. So this is the 3-point sport cord drill, both forward and backwards, that we do at the second week of Phase D. Starting in Phase C, we move away from the step agility exercises and move into the agility ladder. This is more sport specific and puts a lot more demand on the knees. She's double touching in each rung here. Okay, and we usually do this 3 times. The next one we'll do is lateral high knees, which she's going to move in the coronal plane with her legs pumping nice and high. Her hips are controlling where her knees are in space. We go back facing the same direction, working the legs a little differently. Then we go into lateral quick feet, which are ins and outs, and we're going to do this 2 different ways. We're going to do the first one with her leading with her front foot. This challenges dexterity, so she's going to go in and out, and then go for speed. And she's going to go back facing the same direction here. So this is lateral quick feet, in and out with front lead. Now we're going to reverse this, and she's going to do back foot leading. But you can see there's more rotation in the hips with this. It's a little more challenging movement. This is lateral quick feet in and out with the back lead. From there, we'll move into the ollie shuffle. She's going to, it's very similar to what we were doing on the step. She's going to jump up and switch her feet, moving in and out each rung. So a lot of rotation at the hips, and she's going to reverse that. When we first start these, usually we do 3 times down and back of each exercise. The last one we're going to run through we call the icky shuffle, and this is our first real hard cutting exercise. So she's going to start cutting on that outside leg, and she's going to go back doing the same thing here. So these are the ladder agility drills that we do up until the jump program begins.